Well, I apologize for that. I'll make the note. I inadvertently clicked out of that session, so I'm starting the next one with because that was the one that just completed 15A. This is 15B. This is really we start to get into sort of gland by gland. It doesn't take very long because I want to get most of the other glands out of the way and sort of dedicate the next class, whether you listen to this or not. I'm going to start the next. If you listen to it, I'll be starting with diabetes because I really think we need to take our time with that. So, okay, thyroid, right around either side of your Adam's apple, easy to feel. It's got follicles, and that's really where they produce this what we call thyroglobulin, which is again it's a glycoprotein. Nothing unusual about that. It's produced there. It requires iodine for that globulin. And the way it exists, as you will see in the gland, is what we call a colloid. Again, protein and water attracting each other. And for that colloid, that before it can be manufactured or processed into true T3 and T4, the active parts of thyroid hormone. And remember, T4 is active, but T3 is the more active form. And then you'll see it shortly how this is all about. So the colloid forms in the lumen of the glands. And these are typical, think of like a sweat gland with effectively an area where it's surrounded, as you'll see in the images that are here, it's surrounded by cells that appear to be mostly simple cuboidal. And in the middle, and you can see the way it's stained, sort of a pink color characteristically on slides, you see a mass amount of this colloid. Without iodine, it just is going to stay there, and the cells are just going to make more. So those are the follicle cells. There's parafollicular cells produce calcitonin to refresh your recollection from bone, something that's active in children, may have some activity in adults, we're not sure. It tends to reduce blood calcium levels by putting it into bone, so it's important in growing bone. And yet, does it play some role in osteoporosis? Could we use it as a treatment for osteoporosis? I don't know. And so, as we continue, you can see the relationship here. Vast amount of blood supply. Thyroid is a very, very busy gland, and because of that, very difficult. If you have to remove a thyroid, or because thyroid tumors are more common than you think, it's really complex. You really have to be very careful about inducing bleeding or anything like that. So it's rather it's not time it's time consuming because of having to really cauterize, tie off or end cauterize all of these blood vessels. So it's quite a problem. It's a big problem post-operatively with regard to this is what I talk about. These are the parafollicular cells you can see here. They're slightly different. These are the typical follicle cells. They're the ones. Here's this large amount of colloid that you can see here. And what they lead to is T4 and T3. Again, T3 is more active, and this is the unique hormone. Basically, it's tyrosine, a standard amino acid with two molecules, sort of more or less what we would call anti-parallel. They're very symmetrically arranged, and they contain either 3 or 4 iodines. And so they're nothing really more than really an amine-based hormone from the amino acid tyrosine. Vast amount of cells that it impacts. Again, it is very much like a fat soluble because it is a fat soluble hormone. But all the other ones, when we talked about all the ones from the pituitary, effectively all those inhibiting and release hormones, all of those are G protein mediated passageways. This is the first one before we get to the adrenal gland and before we get to the actual reproductive hormones, where we're looking at something that basically passes easily through the cell membrane, all cell membranes, and its receptors are located on the interior within the cytoplasm. It binds there, is able to pass even that complex of receptor and hormone is able to bind there, travel relatively easily through the nuclear membrane and impact transcription and translation. And effectively, it's basal metabolic rate more than any other process that's there. The more it's there to keep it at a normal range. If there's too much, it accelerates it. If there's not enough, it decreases it. So all of these things, critical for all of these capabilities, skeletal nervous system, reproduction, you name it. Any adversities when it comes to thyroid, whether you're hyperthyroid or hypothyroid, are difficult to manage. Hypothyroid is easier to manage because we've had thyroid supplement for a long time. Hyperthyroid is a little more difficult to manage. That's there. And as you can see, the gland stores those, and effectively, when it receives a signal, it makes that globulin, it makes that, what you see, that colloid that you see, and it's discharged into the follicular lumen. And then iodide ions, I with a negative charge, required effectively, as you can see, without going into the chemistry, you have these two units, the mono and the diiodotyrosine, and they link up. So it's, as you, and you'll see illustratively, you'll show you T3 or T4, and so then they basically combine, that vesicle combines. Basically, it's exocytosed, and so the colloid, as you can see, is endocytosed into. Let me show you, and then combined with a lysosome. The lysosomal enzymes cleave off the T3 and T4 from the thyroid globulin, and that allows the hormones to be actively secreted in the bloodstream. They require a carrier molecule in order to get them to the cell. It's mostly T4, but T3 and T4, and once it gets to tissue level, the active form is T3. So T4 have some activity. You can go through the sequence. I'm not really going to ask you about it. But effectively, you can see the symmetry of the molecules. Here's the mono, here's the di, and you can see the T4s with the 4 iodines and the T3s basically combining, then basically effectively being exocytosed directly. And you'll find they have to get a carrier molecule. That's there. So they're called these thyroxine binding globulins, bind to the target. T3 is 10 times more active. Okay. And all the enzymes do on site when it gets to its target is cleave off one of those iodines to activate it. And you get negative feedback classically. So TSH, the stimulating hormone, again, as we talked about, growth hormone, inhibitory hormone. We don't, in the absence of that, growth hormone, dopamine, and increasing levels of cortisol and iodine. So all those signal that we're not going to be utilizing it. As you can see, the negative feedback is overcome during pregnancy or certain other things in infants, as you can see. So there's certain scenarios where it bypasses that mechanism. But what's really very interesting, and you can see just read through all the things it contacts. And we paint with a broad brush when we talk about hypo and hyperthyroid. Hyposecretion, low activity levels, thicker, dry skin, chill, body's not functioning terribly well. The edema is a characteristic. Depending on what's causing it, there may be some actual mental disease or effectively, mental disabilities that are there. Lethargy is common. If it's due to iodine, this is what we don't see in this country because we iodize salt and have for surely more than 100 years. In other countries which don't have those controls, we still see the occasion of the goiter. Effectively, what's happening, the iodine isn't in the system, that colloid accumulates in the bloodstream. What the body reads is an absence of T3 and T4. So the hypothalamus says, oh, we don't have enough thyroid hormones that are active, tells the thyroid to make more. It makes more colloid and continues and continues. So it's erroneously looked as a tumor when in reality it's not. So effectively, the lack of iodine, you can see this is sort of that pathway. The thyroid enlarges, critical for all of these things. The congenital aspect, medication induced, other problems you can see here. Very important to replace. That's a goiter, not a tumor. You can see this is a very interesting one. It's an autoimmune, and it causes fluid to build up behind the eyes, so you get what's called an exophthalmic goiter. It's not really a goiter in the classic sense, but the eyes protrude, autoimmune disease, antibodies mimic thyroid stimulating hormone, and so they continue to stimulate the thyroid. and it goes against the follicular cells. And this is all hyperthyroid, elevated metabolic rate, people secreting a lot, very cold, well, not cold and clearly, but hot, sweaty, agitated, almost like a hypoactivity disorder, very rapidly moving bowels, urination, etc., weight loss. You see all of those things, and it's called Graves' disease. And again, sometimes you have to literally remove the thyroid or use radioactive iodine and compensate with. Again, we have thyroid supplement available. There's a classic. It's one of the things you look for. Again, the calcitonin, not a whole lot other than what I've told you, and getting those limited cells. So, and lastly, we'll do the parathyroid. Commented on it in bone. There's typically 4, as many as 8 on the posterior aspect of the thyroid. When we remove a thyroid, you be very careful to leave those thyroids you can do without, parathyroids you can't. They secrete one hormone, parathyroid hormone, the single most important hormone for maintaining calcium levels in the bloodstream. And if nothing else from this course, the importance of calcium is continually underscored. So it's the leader in this, and it works in 3 different areas. It can pull it out of bone by activating osteoclasts. It can cause the kidney to retain more calcium and in turn excrete more phosphate. They're tied that way. And in the intestine, with the aid of vitamin D, it absorbs calcium into the gut. Those are the 3 ways it works. You must know those. So again, on bone directly by way of osteoclasts, breaking down bone itself, particularly cortical bone, releasing the calcium into the bloodstream. So it works on bone itself, not just the deposited salts, but the bone itself. So it probably plays a significant role in osteoporosis in certain instances. It works in the gut to absorb it by way of your diet with the aid of vitamin D, and lastly in your kidneys by effectively increasing its retention at the expense of excreting more phosphate. So all of those things, you can see it all here. I just restated it for you. You see it stated here this way. Uh, Typically, tumors are unknown causes. There's a lot. I mean, there's big problems. So bones will soften, and we the myriad of things that calcium does, whether it's kidney stones. I've seen some cases of this. Okay, easily fractured bones that are there for people with disorders. They're very difficult to manage, and you don't see a whole lot. I mean, it's mostly hyper. Hypo is really just probably not compatible with someone's going to live very long, I would say. We will stop at the adrenal glands because it's a good place to stop to lead into the pancreas and insulin and finally into diabetes. Thank you. And we'll talk about that more in class.